All right, so this final voiceover for this unit will be on preterm infants. So preterm infants have several developmental concerns that make them unique as far as what we might need to do for care. So a couple of things to think about is that because they're premature, there's a decreased amount of surfactant, which increases their risk of respiratory distress syndrome. Their ductus arteriosus may not constrict with increased oxygen because there may not be an increase in oxygen that occurs in these preterm infants, and so that ductus arteriosus may remain patent. They also have a higher body surface area to weight, meaning that they're more at risk to lose heat and to have a harder time maintaining temperature. This also relates to their little amount of sub-Q fat. So they have a decreased amount of sub-Q fat as well as a decreased amount of brown adipose tissue, and so they're going to have increased risk of thermal regulation problems as a result. Their skin is also thinner, and their posture tends to be in more of an extension versus flexion, and so both of those things, again, create some challenges with thermal regulation. Some other developmental concerns that are present in the newborn or the premature infant includes some gastrointestinal challenges. So there's an increased risk of aspiration due to an immature sphincter. They also have a poor suck, swallow, breathe reflex because that's not established well until around 34 weeks gestation. They have a small stomach, so it's hard to achieve the caloric needs for growth because without doing some kind of higher calorie formula or breast milk fortifier. Decreased ability to absorb or convert some nutrients, as well as an increased use in metabolic rate and O2 demands while they're suckling. So they may actually use more energy to try to suckle or eat by mouth than they would gain from the feeding. And so we have to balance that demand. And then they have an increased risk of neck. So neck is necrotizing enterocolitis. And so neck occurs due to hypoxia to the intestines. And this can occur as a result of illness or cold stress because blood is shunted to the vital organs and not to the intestine. And so as these infants become stressed, that is a risk of neck. And so we hold feeding sometimes very regularly in preterm infants to decrease that potential for bowel death. Some of the renal developmental concerns are associated with the decrease in GFR, so there may be some oliguria. They cannot concentrate urine, and so this is definitely a concern in preterm infants with hydration levels, and they're predisposed to metabolic acidosis, so we're really monitoring carefully. That metabolic acidosis occurs partly because of a decreased buffering capacity of the kidneys, and so they may need some sodium bicarb administered to decrease this risk. Other concerns can occur as a result of understanding that IgG transfers mostly in the third trimester, so infants born prior to that time frame do not have as much of that immune globulin. Their skin is very thin, and they tend to have many invasive procedures, thus increasing their risk for infection. Their brain growth and development is really rapid in the third trimester, and so infants born before that time have to do this growth and development outside of the uterus. This leads to a risk of intraventricular hemorrhage because the blood vessels in the brain are weak, and a risk for hydrocephalus. They also tend to be less organized in the reactive states because of that immature neurologic function. So when we think about nutrition and fluid, their caloric needs vary, but they need a lot of protein to meet their growth demands. We may need to supplement oral feedings because of that risk of expending too many calories to try to obtain a feeding orally as opposed to supplementing it. We need to monitor for tolerance to ensure that we're not increasing the risk for neck. Is the bowels moving appropriately, or do we need to hold the feedings? And then they may also need some vitamin supplementation. Feedings would be held for all ill infants, and we may do some TPN if they're unable to feed for a period of time. Some things we need to think about for feeding types. So in order to feed a preterm infant with a bottle, they must have a coordinated suck, swallow, breathe, and so that takes a little time to develop. Once that is developed, they'll usually demonstrate a rooting reflex, and that can indicate that they're ready to nipple a feeding through a bottle. We don't let them try to do that oral feeding from the bottle for longer than 30 minutes, because that's really where they start to spend too much energy trying to obtain the feeding than what they're going to gain from it. And gradually over time, we would increase the number of feedings that they are able to tolerate orally as they age. We do schedule feedings initially as well to ensure that because they won't always wake up to say that they're hungry like a full-term infant would. Breastfeeding can also start once there is a coordinated suck, swallow, breathe, and we gradually increase the number of feedings the same way we would with a bottle. Some institutions will monitor weight before and after breastfeeding to estimate intake to see if they're getting an adequate amount. Gavage feeding is generally done when infants are less than 34 weeks. The orogastric route is preferred to the nasogastric, and it's usually done in a bolus setting. All infants should receive minimal enteral nutrition, so this means they should get a small amount to stimulate function in the gut. We're not going to focus on individual nutrients, but we do need to think about fluid requirements in these preterm infants. And so we do daily weights, and we use humidity in the extremely preterm infants to avoid excessive fluid loss through the skin. We use umbilical lines, PICC lines, or central lines commonly in a NICU setting to give supplemental fluids through those devices because of the long-term nature and need of supplemental fluids. There are a few long-term concerns with preterm infants. We're going to talk about the two key ones here and then some other general. Retinopathy of prematurity previously was related most commonly to high levels of oxygen use, and this resulted in an abnormal development of the blood vessels in the eyes that could lead to a detachment of the retina in severe cases. One thing that we've learned over time, and we've seen a decrease in retinopathy of prematurity, is that we thought we needed to give enough oxygen so that the newborn or preterm infants had an oxygen saturation of above 95%. And that's commonly what we do for adults. What we've learned over time is that we really don't want preterm infants to have an oxygen saturation that high. We actually like them below 95%, and even sometimes we're okay if they're above 85%. And so they are allowed to sat much lower than what we would be comfortable with in an adult. And because of this decreased use of oxygen, we've also seen a decrease in retinopathy prematurity. Now, just because we're not adding additional oxygen does not mean that they may not be on a ventilator. You can be on a ventilator on room air and still have the same percentage of oxygen that would be present in room air. We're just not giving additional oxygen even when they need some assistance with breathing. So keeping that kind of in mind, we let them sat a little bit lower, and that's been really beneficial. There is a risk for bronchopulmonary dysplasia that results from damage to the alveolar epithelium, and that's related again to increased use of oxygen and just use of ventilators in general in the premature infant. Can result in some oxygen dependence as well as an increased risk of respiratory infections. Some other concerns is that there is some delayed development with speech. There are some neurological defects that can be increased risk with preterm infants, such as cerebral palsy, hydrocephalus, seizures, and learning disabilities. And there is an increased risk of hearing loss in a preterm infant. When we look at preterm infants, we want to look at their corrected age. And so we actually look at corrected age until they're about 2 years of age. And so this means that if we have a baby that was born at 26 weeks gestation, we wouldn't expect them when they're 1 year of age chronologically to be the same size of an infant who was born full term. And so we correct that age based on how premature they were. And you see an example here, and we'll do a couple other examples in class. And so we use the corrected age until around 2 years, because generally preterm infants have caught up pretty well by 2 years of age, if they're going to. Some acute concerns, not long-term concerns, but what you might see in the NICU setting include some apnea of prematurity, which is common when they're less than 36 weeks, but must be distinguished from obstruction or reflux. The patent ductus arteriosus, because it doesn't always close in those infants, and so if it becomes symptomatic, they may need surgery or meds to lead to closure of that. They may need surfactant to treat respiratory distress syndrome. We may be monitoring for intraventricular hemorrhage, which can be common in infants less than 34 weeks, as well as anemia of prematurity, which occurs for a variety of reasons, but we do commonly see some blood transfusions occur in the NICU setting. And so anemia of prematurity occurs because of the rapid rate of growth that's required. They have a short lifespan of their red blood cells. They have a lot of blood sampling going on, decreased iron stores because they weren't in mom as long, and deficiency of vitamin E. And so there's a variety of things that we might see in that. Nursing care. So what are we doing for nursing care of a premature infant? So we're ensuring that the respiratory status is stable, monitoring for respiratory rate, oxygenation, all of those things, and assisting with maintaining that, whether it's through a ventilator or CPAP or BiPAP as needed. We would maintain that neutral thermal environment. So these infants are at risk for thermal regulation problems. So we're really going to do some key things to help to do that. So looking at skin to skin, great way to maintain a neutral thermal environment. Warming and humidifying anything that goes into baby. So warming and humidifying the oxygen, warming and humidifying the air inside the isolette, using a double-walled incubator to avoid heat loss from that direction. Not placing the baby on cold surfaces. Putting a cap on baby's head because they can lose 25% or 25% of their body size is in their head, so we want to avoid losing heat in that direction. You kind of grouping cares together so that we're only accessing that porthole into that incubator for a short period of time. Warming formula or breast milk, warming IV fluids so that we're able to not introduce something that's room temperature that would further decrease their their thermal regulation status. Maintaining fluid and electrolyte status, so we may be observing, making sure you're assessing things like the fontanelle, the urine output, the weight to monitor for fluid and electrolytes, skin turgor, and adjusting those as appropriate. Providing adequate nutrition via orogastric or nippling feeds, but monitoring for tolerance of that. So are they processing that through their bowels in a adequate manner? Do we see some abdominal distension or vomiting or diarrhea that might indicate lack of tolerance, or an increase in residuals before a feeding because they haven't processed the previous feeding? Preventing infection, increasing parent-infant attachment, providing supportive care for developmental purposes, so keeping a calm, quiet environment, maybe placing blankets over the top to decrease the lighting changes, and then preparation for discharge. Parents are going to need a lot of education and discharge planning when we are going home with a baby who's been in the NICU who might have some additional long-term needs. And so prepping for discharge right from the get-go and providing adequate education to these parents is going to be very, very important.